Hello, in this video I'm going to be talking about ductal carcinoma in situ, also called DCIS, non-invasive breast cancer, or stage 0 breast cancer. What is DCIS? What does it mean in terms of your outcome, and how do we treat it? This is really a high-level overview of ductal carcinoma in situ. And I'd love to invite you to go to Yerbba.com to get your personalized report. Yerbba cross-references your medical records after you give us permission with the latest medical evidence and generates for you a summary of every treatment by date, every pathology finding, everything that we know about you, cross-references with the current medical evidence to generate for you a report that's updated about the options for you in your case. It's not a static report, it keeps updating, and it's not the same as your portal. Even though you go to your portal to give us permission to access your records, it's very different from the type of information you get in your portal. So again, go to Yerbba.com to get your personalized report. Ductal carcinoma in situ is cancer. It's not really a precancer, it's actually malignant. The cells in the breast are cancerous cells. But unlike invasive cancer, they're confined within the duct. They don't extend through the basement membrane into the normal tissue of the breast. In that way, it's a very different situation. The purpose of treating ductal carcinoma in situ is to prevent it from becoming invasive cancer. Now, an important note, we don't know which DCIS will progress to invasive cancer. It's very likely that not all of it will. We are working on trying to figure out which DCIS will progress and which DCIS won't progress to invasive cancer so that we don't overtreat this very common condition. DCIS is generally treated in order to prevent it from progressing, and also because once you know you have something in the breast, it's very difficult for people not to want to rush to treatment. Most DCIS is detected with mammogram, but about a third of people will feel a lump in their breast. By definition, DCIS doesn't spread to the lymph nodes. So we don't do lymph node dissection, with one exception. If somebody's having a mastectomy with reconstruction, and if it's a large tumor in a young person, there is a possibility that there could be invasive cancer, which we won't know for sure until the entire specimen is looked at under the microscope. After reconstruction, it's really hard to do a lymph node sampling. So with DCIS, where somebody's having a mastectomy with reconstruction, some people will actually have a sentinel lymph node procedure where the lymph nodes are identified and then looked at under the microscope. But for the most part, DCIS does not require examination of the lymph nodes. So surgery is the main form of treatment, and there are generally two options. One is wide local excision, where we take a wide margin around the tumor. It's local because it's just in the breast, and excision means we're cutting it out. This might also be referred to as breast conserving surgery, lumpectomy, or some other terms like quadrantectomy or segmental mastectomy. Those are the terms you might see in your pathology report. The other option is a mastectomy, which is removal of the entire breast, again, without lymph nodes. A mastectomy removes all of the breast tissue possible, and somebody is left with the skin overlying the breast. People can have reconstruction after mastectomy. You can check out our video on reconstruction. We'll put a link to that below. The reason somebody might have a mastectomy is because of their personal choice, because the DCIS is too large within a small breast, and it will be hard to get a surgical outcome that you're happy with. The other reason people might have a mastectomy is if the DCIS is in multiple areas of the breast. So it might be small areas throughout the breast, but there are many areas, and so it's going to be hard to get good, wide surgical margins with a wide local excision. So it's possible people might be advised to have a mastectomy. having a mastectomy by choice does not actually improve outcomes in people with ductal carcinoma in situ. Your outcome is really not better. If you have a wide local excision, radiation therapy may be offered. There is a test, the Oncotype DCIS test, that can help us figure out if radiation therapy is going to offer any benefit. So that's something you might be offered. It's a test done on the tumor itself. There are also some people with small DCIS with wide margins who are older who can omit radiation therapy. I'm not going to go into that right now. I really want to stay high level. But in general, sort of the party line is radiation therapy after surgery for DCIS, with quite a few notable and important exceptions. Chemotherapy is not part of treating ductal carcinoma in situ. I do want to say that it is possible there is invasive cancer within the DCIS, and that might be described as microinvasion, where there's a very tiny area of invasive cancer breaking through the basement membrane. That is not actually upstage to invasive cancer unless there's a big area, in which case it's not actually DCIS, it's actually invasive breast cancer with a lot of DCIS. So it's important, if you get your pathology report back and you see invasive cancer, to figure out, is this invasive cancer with a lot of DCIS, or is it DCIS that happens to have a tiny area of invasive disease? Because that will determine how the lymph nodes are managed and whether or not chemotherapy might be offered. Again, I don't want to go into it too much, but pure DCIS is not treated to decrease the risk of the cancer coming back in other parts of the body, because pure DCIS cannot come back in other parts of the body. So we do offer endocrine therapy. Anti-estrogen therapy is another name for that in people with DCIS who keep the breast, because it can decrease the risk of DCIS coming back if you have wide local excision or breast conserving surgery. It can't improve survival. So if you're on endocrine therapy for DCIS and you feel miserable, we recommend that you stop the anti-estrogen therapy. We as a healthcare field, not Yerbba. We don't make recommendations to you specifically, but coming off endocrine therapy is very reasonable because it's supposed to improve your quality of life. It's supposed to decrease the chance that you have to have another surgery on your breast. If you'd rather have another surgery than be on tamoxifen or an aromatase inhibitor for 5 years, we're kind of defeating the purpose. I hope this is helpful. Drop any comments or questions below. Have you had DCIS? What kind of treatment did you have? We read your comments and get back to you within 1 to 2 weeks. We love hearing from you. Please be kind. We're normal people too. And thank you for watching.